I'm Dean Kereiakes, and I am the president of the Christ Hospital Heart and Vascular Institute and professor of clinical medicine at The Ohio State University. And we're here today to discuss a concurrent publication with a late-breaking trial presentation at PCR. And this publication will appear in JACC Cardiovascular Interventions. The lead author of the publication is Eliano Navarese, who is also here today with us. The title of the paper is The Effects of Elective Coronary Revascularization versus Medical Therapy Alone on Non-Cardiac Mortality, a meta-analysis. You know, a prior meta-analysis of all randomized trials comparing revascularization plus medication versus medication alone for stable coronary syndromes demonstrated a significant reduction in cardiac death following revascularization, with a survival advantage proportional to both the duration of follow-up and the magnitude of spontaneous MI reduction. A similar cardiac survival benefit was associated with revascularization plus medication versus medication alone in the Ischemia Extend trial. However, Ischemia Extend had an increase in non-cardiac related deaths following revascularization that counterbalanced the overall mortality comparison between treatment arms.
Thank you, Dean, for the introduction. Um, I am Dr. Eliano Navarese, Associate Professor and Director of Research at Cardiovascular Department of Nicolaus Copernicus University, Poland. And we conducted a large-scale meta-analysis, including 18 randomized trials involving over 16,000 patients, comparing elective coronary revascularization plus medical therapy versus medical therapy alone in patients with chronic coronary syndromes. No significant difference were detected in non-cardiac mortality between the assigned treatment groups with absent heterogeneity. By meta-regression, follow-up duration did not affect non-cardiac death rates with revascularization plus medical therapy versus medical therapy alone. Bayesian meta-analysis, controlling for potential residual uncertainty, was consistent with the standard approach. The trial sequential analysis indicated that a sufficient level of evidence was reached to demonstrate the absence of differences between treatment strategies with respect to the occurrence of non-cardiac mortality. In this framework, prolonging study follow-up or adding further studies will be futile. These findings might be considered when estimating the benefits of intervention to treat patients with chronic coronary syndromes.
This means the non-cardiac mortality excess in Ischemia Extend reflects a statistical type 1 error and obscures the 22% cardiac survival benefit associated with revascularization plus medication versus medication alone. In addition, the premise of the accompanying editorial rests on the hypothesis, unproven, that radiation exposure from diagnostic therapeutic evaluation and treatment during revascularization procedures, including CABG, promotes or accelerates precancerous conditions into manifest cancer with death occurring within 5.7 years average follow-up. This hypothesis must include the average survival following cancer diagnosis, which infers the cancer promotion and induction is quite rapid. You know that competing causes of death to 5 years after PCI was identified by Spoon at the Mayo Clinic, Circulation 2014, and over a 25-year time frame, the primary cause of death to 5 years after PCI shifted from cardiac to non-cardiac, primarily as a result of a 33% relative reduction over time in the incidence of cardiac-related death, not to a relative increase in non-cardiac related death, primarily cancer and chronic disease. Similarly, Peterson et al. In JACC 2014 noted a dynamic shift in the cause of death from cardiac, usually early within 5 years, to non-cardiac, 5 to 7 years or more after PCI for STEMI. In the context of the dynamic and competing causes of death over time following revascularization, We agree that better attribution and adjudication of causes of death in clinical trials is desperately needed, and that cardiovascular death due to mechanistic plausibility should be the primary endpoint of interest in trials that compare revascularization plus medical therapy versus medical therapy alone. I believe our editorialist agrees with us as he's previously written in commentary regarding our prior meta-analysis on cardiac death, and I quote, in revascularization trials, deaths not possibly affected by revascularization, e.g. from cancer or chronic diseases, should not be counted in the primary endpoint for several reasons. He goes on to make the point that all-cause death would require larger power to detect differences between the treatment strategies. We rest our case with the conclusion that elective revascularization saves lives, reduces cardiovascular death in the long run. Please visit jack.org and see our manuscript.